Started the timer and here is your question. Right. So if you have read and understood considering its surgical pathology section, kindly tell me what are the differential diagnoses that you'll consider?
Ma'am, the differential diagnosis for this patient is first one is the familial adenomatosis polyposis coli. The second will be the maybe inflammatory bowel disease, ulcerative colitis or ulcerative colitis, and third will be the any polypoidal lesion of the colon need to be evaluated further. This will be the my differential diagnosis for.
Can you please tell me what are the investigations that you will ask for to confirm your diagnosis?
As the patient has already done the colonoscopy, it's better to take the biopsy of the polyp first thing. The second thing, because there is a family history of cancer in the family, so I need to do genetic workup for the patient for FAP gene.
What are the genes which are involved?
This is the APC genes, colon genes, which is located on the chromosome number 5, and patient needs to be evaluated for that.
What is the function of this APC gene?
Actually, it's a proto-oncogene, which is the normal functioning gene. If it will get mutated, it will cause hyperplasia.
Yes.
All right. And then
Yes. What are the other genes that you'll consider?
The other genes are KRAS gene,
and
KRAS gene, and P53
what's the function
gene.
Of loss of P53 gene?
Actually, P53 is a guardian gene for the cells. If there is any DNA damage to the cell, it causes repair, and if it fails, it causes apoptosis for the cell. And unfortunately, if it will get mutated, then there will be hyperplasia. There will be uncontrolled
There will be damage of DNA.
Damage of DNA, and sometimes it will skip and cause uncontrolled growth of the cell, which can lead to the carcinoma.
You said there is a history of carcinoma in the family, so and you're also considering the genes. What is the protocol for surveillance that you can follow for this?
Actually, if in the family these APC genes are running, then we have to start the colonoscopy at the age of 15 years. 15 years, if it is there, then yearly. If it is not there, no polyps are there, then after 5 years we need to look for any polyp. And if there is a polyps, then we have to do it yearly. And if any suspicion, any time of any malignancy, then we have to plan for surgery, either pan-colectomy for this patient. Yeah.
What is the plan of management that you'll offer to this patient?
Plan of management, just this yearly follow-up colonoscopy. And if during colonoscopy, anytime these patients have a suspicious lesion, suspecting of any malignancy,
has already been done. Please tell the next step.
Next step will be if there is a suspicion of a
7 millimeter ulcerated
lesion, then we will go for pan-colectomy, because there is high chance of developing a carcinoma in the,
What is oncogenes?
Oncogenes are those genes which, when expressed, lead to uncontrolled growth, that will lead to carcinoma. These are the carcinomatous genes, oncogenes.
Okay, can you please tell me what are the types of carcinomas which are present in the colon?
It can be adenocarcinoma. It's the most common carcinoma. Adenocarcinoma is the
What are the
most common.
types of adenocarcinoma?
It is the
Adenomas, types of adenomas.
adenomas. Types of adenoma is tubular adenoma. It's villous adenoma, or it is tubulovillous adenoma.
Which ones of these are non-neoplastic?
Tubular is non-neoplastic. Villous is neoplastic. There's a high chance of malignancy in villous adenomas.
Tubular and villous both are neoplastic and inflammatory as well.
Both are neoplastic, but malignancy, both are neoplastic.
Non-neoplastic are hematomatous and metaplastic.
Yes.
Okay, which one has the highest chance of causing malignancy?
Villous adenoma.
Okay. What is the malignant potential of adenoma that depends on? Can you name few factors?
Sorry, ma'am, I couldn't get to the question.
What are the potential of malignancy of adenomas that depends on? Can you mention few factors?
Yeah, it's a APCG in familial adenomatous polyposis.
No,
the adenoma has,
you just told me types of adenomas, and then the diameter of adenoma, and then the degree of dysplasia. That's how simple it is. Okay, can you mention few extracolonic familial adenomatous polyposis?
Ma'am, extracolonic, it can be present in the duodenum. It can be present in the, there may be a gastric carcinoma. There may be an osteoma sometimes.
I asked you extracolonic, so you have to tell me extracolonic, not from the gut, in the stomach, and then?
In the stomach, and then osteoma sometimes, neuromas we have.
Give some examples of ectodermal and endodermal origin. Okay, we'll come back to this one later.
Okay.
Can you please tell me, this patient was a known case of endometriosis. So what is endometriosis and how it occurs?
Endometriosis, it is an ectopic endometrial tissue when it is outside the uterus cavity, uterine cavity, anywhere in the abdomen, as in it's a normal endometrial tissue, but at abnormal place. It's ectopic.
What are the common abnormal places where this tissue
It's
can
around
be found?
it can be around the ovaries. It can present in anywhere in the abdomen, intra-abdomen, it can most commonly it can present in the ovaries or on any part of the gut.
How the patient presents which suffers from
Usually the patient complain of pain abdomen, and usually it is related with the menstrual cycle.
Okay.
It is yeah.
What lifestyle changes can you suggest to this patient which can reduce the risk of colon carcinoma?
We can advise from high fiber diet.
And
we can advise from less fatty meal. We can decrease the fat contents from meal. Advise high fiber diet. Avoid smoking.
Yes.
And regular exercise.
Yes.
And regular follow-up.
And limited alcohol. Okay.
Yeah.
Right. Yes, one question that we can do, it says that the largest polyp was 7 millimeter and ulcerated. What is ulcer?
Ulcer, it is the breach in the continuity of the lining of the epithelium.
If there is an ulcer and it is necrotic, what do you understand by that?
It means that there is a tumor. Necrosis means there is a ischemia in the distal end, and
not quite.
Yes.
Presence of what would be there?
Presence of carcinoma there.
Carcinoma, not always.
Carcinoma.
You have to You have to read the definition.
This
All
is
right.
of course
Can you
normal.
please help me read this diagram?
Yes, ma'am. Ma'am, this diagram is a picture of a
Is it a
ma'am,
picture?
because these are host stations. This is a colonic picture. This is a colonic picture during colonoscopy showing multiple
Okay.
polyps.
Yes.
Showing multiple polyps, and it goes towards this the picture of familial endometosis polyposis coli.
Right. Multiple polyps in different
Yeah.
sizes,
And there are
diameters.
host
Yes.
stations of because there are incomplete rings, mucosal folds around the colon. So most probably
What is this yellowish stain in here as well?
it's just a intestinal content, ma'am.
What is this
It is
yellow?
yellow.
And what is this glistening?
Ma'am, these are the host stations, mucosal folds.
No. Have a look closely. I'm not talking about the what you are
On
saying. This is like foamy, glistening, liquid. You have to describe. Tell me what that is.
foamy
How
glistening.
this fluid or presence of this is different from this yellow one.
Hmm.
And you can
Sorry,
see it here
ma'am.
as well. What more can you tell? Can you see any ulcers here? Can you see any necrotic, ulceratic polyp? Are all polyps of the same size and diameter?
These are almost all the polyps are the same size. There are multiple polyps there. I couldn't see the ulcerations, but these
So
are
you have
multiple
to
polyps.
mention. There are no, you can't see the ulceration, but what would be the biggest size approximately that you can mention?
Mhm.
Some of these are, they appear to be bigger.
Yeah,
All right. Thank you so much.
thank you. What is this yellowish water?
Started your timer and here is your question. Yes, so if you have read and understood, considering this surgical anatomy station, kindly tell me if you can identify the image, the structures on the left-hand side from A to D.
From A.
Which side of the leg are you looking at?
Ma'am, this is the left leg, and I'm looking at the interior side.
Is it interior? The lateral side.
Looks like it. Yeah, anterolateral. A and B are marked in the interior side.
Yes. Okay, what is A, please? How many compartments there are in the leg, please?
Ma'am, there are 3 compartments, and the third one, that is the posterior one, it is divided into 2 compartments further, superficial and deep.
Okay, what are the contents of these 4 compartments?
The interior compartment, it consists of tibialis anterior and extensor hallucis longus, extensor digitorum, and peroneus tertius.
Yes.
And the lateral lateral compartment, it consists of 2 muscles, peroneus longus and brevis. The posterior compartment consists of superficial and deep. Superficial consists of gastrocnemius, plantaris, and soleus, and the deep one consists of popliteus, flexor hallucis longus, flexor digitorum longus, and and tibialis posterior.
Okay. What are the nerves of each compartment?
The anterior one, it gets its nerve supply from the deep peroneal nerve, the lateral one from superficial peroneal nerve, and the posterior one from the tibial nerve.
Okay. Right. Can you tell me what are the muscles which supply peroneal nerve supplies? And what's the sensory supply of peroneal nerve?
Ma'am, sensory supply is on the lateral aspect of the leg, and it divides into superficial and deep. So the superficial one supplies the the dorsum of the foot, except for the first rib space, which is supplied by the deep peroneal nerve, and the muscular supplies to the peroneus longus and brevis.
Okay, what happens if there is a transection or injury of common peroneal nerve?
So, ma'am, the person would not be able to evert the foot, and there would be loss of sensation on the lateral aspect of the leg and the dorsum of the foot, except the first dorsal web space.
Yeah. Right. Yes. Okay. Can you please tell me the tendons which pass through the lateral malleoli, behind the lateral malleoli?
This is the tibialis posterior, ma'am.
Okay. Is that all? There are
No, there are others as well. There is tibialis posterior, flexor digitorum longus, and flexor hallucis longus as well. Then there are some nerves as well that pass, like posterior tibial nerve, and also some vessels like posterior tibial artery and posterior tibial vein.
Good. Okay, can you please tell me what are the root value of plantar reflex?
Ma'am, it is plantar reflex. It is S1.
L5, S1. Okay, right. Can you please identify images or the structures on right hand side image, please? Which one is A?
Ma'am, A is it's a muscle, but
It's not a muscle, it's a vessel.
I don't know, ma'am. I can't tell A.
Could that be popliteal artery? If I tell you it's popliteal artery, then what would
the
be
angiogram? The angiogram, okay.
The right hand
okay, the
side.
angiogram. It is.
Sorry, I
Yes,
did
yes,
say right hand side.
Yes. So, ma'am, A is the popliteal artery, and it is giving rise to B, which is the anterior tibial artery, and then it is giving rise to the tibioperoneal trunk, which is dividing into C, which is the posterior tibial artery, and D, which is the peroneal artery.
Peroneal artery. Okay, good. Right. Can you please tell me which structure is this? Picture A and B. What are you?
Ma'am, this is
at?
the popliteal fossa.
Yes. Kindly tell me the boundaries of popliteal fossa.
Ma'am, superiorly on the lateral side, it is formed by the biceps femoris, and inferiorly it is formed by the lateral head of the gastrocnemius and the plantaris. And on the medial aspect, superiorly it is formed by semimembranosus and the semitendinosus, and inferiorly it is formed by the medial head of the gastrocnemius.
Can you identify the popliteal artery in the images, both A and B that you're looking at?
Yes, ma'am. In image B, it is number 8, and image A, it is behind 17.
Yes.
I think there is
good
number.
Right.
Yeah.
Right. Can you tell me the contents of popliteal fossa from medial to lateral?
Yes, ma'am. From medial to lateral,
superficial to deep. Sorry.
Okay, ma'am. Superficial to deep, it would be tibial nerve, common peroneal nerve, then popliteal vein, popliteal artery. Then there are also some other nerves like the posterior cutaneous nerve of the thigh and the genicular branch of the obturator nerve, and deep inside are the parotid, the popliteal lymph nodes.
Can you please tell me, right, the lymph nodes in the popliteal fossa, they drain where?
Yes, ma'am, the efferents from the popliteal lymph nodes, they would go into the subinguinal lymph nodes, and some of the efferents, they also travel along the great saphenous vein into the inguinal lymph nodes.
Following the course of short saphenous vein, right?
Yes, ma'am.
Yeah. Okay. Right. What are the bursas which are present around the knee joint? Can you name few?
Baker's cyst.
Baker's cyst one. And can you name few others? All right. If there is a bulge in the popliteal fossa, how would you differentiate it from popliteal artery aneurysm?
Ma'am, popliteal artery would be beating. It would be having pulses.
Okay. Right. What more I can ask you? Right. You told me, okay, you told me about the injury of common hernia nerve, it's most common. What causes foot drop, injury of which vessel?
Ma'am, common peroneal nerve.
Okay. Any
Damage to
other?
common peroneal nerve.
Any other vessel? Nerve, sorry. Sciatic nerve as well.
Yes, ma'am, sciatic nerve from the above, but it has to
Above,
also
right.
also has to involve the common peroneal nerve.
Right, okay. Yeah, mostly I've asked you. All right, you can maybe tell me the origin and insertion of quadratus femoris muscle.
Which one, ma'am?
Quadratus femoris.
Okay, ma'am. Quadriceps muscles, they are divided into four: vastus medialis, lateralis, and intermedius. And the short and long head of the quadriceps, and that is the biceps. So the vastus lateralis, it arises from the lateral lip of linea aspera on the femur. The vastus medialis, it arises from the medial aspect of linea aspera. The vastus intermedius, it arises from the shaft of the femur, and all of them attached to the lateral, medial, and anterior surface of the patella. And the biceps femoris, that has the short head, it arises from the anterior inferior iliac spine, and the long head, it arises from the I think aces, and then they all both attach into the patella.
Okay, what is the action of quadratus femoris muscle?
Ma'am, when it contracts, it causes extension of the leg at the knee joint.
It's the lateral rotation of the thigh.
Yes, ma'am, along with lateral rotation.
Right. Yeah. Thank you.
Okay, thank you, ma'am.
And here is the question. Right, so if you have read and understood considering the critical care scenario, kindly tell me, how would you manage this patient next?
I will manage this patient according to critical of surgical ill patient.
Yes.
Patient is in spinal shock due to some epidural blockage, epidural anesthesia, and I will manage by giving IV fluids, sitting posture, stop the epidural drug in the epidural catheter. Stop is very important.
Okay,
and
can
then
I stop you and can I request you to tell me in the order you'll do it? You'll make the patient sit up and then you'll stop the fluid. Then you'll
fluid.
give, then what would you do? What would be the next step?
Yes. Then I will give oxygen,
Very
and I
good.
will inform the anesthetist and operating surgeon and prepare
Okay.
the ITU.
Yes. All
And
right.
give other
Yes.
drugs are inotropes and vasopressors can be given.
Very good. Okay, now that you've told me how you'll manage, can you tell me what might be the cause behind it?
Yes, it is due to higher level of epidural anesthesia, and it causes a T3, T4 level. So it blocks the synthetic
One,
outflow.
high epidural block. Then what else could it be?
Sympathetic outflow is blocked and parasympathetic is working. So there is bradycardia and hypotension.
Okay. What else could that be?
Vasodilation, due
Distributive.
to vasodilation and hypotension will occur, and bradycardia will occur due
Okay.
to
Yes.
this happen.
What are the other differential diagnoses that you can consider?
It may be due to hemorrhage, due
Okay. Yes.
to due to
Paralysis of diaphragm,
intercostal
pneumothorax
muscle
or
paralysis,
pneumothorax. Yes.
pneumothorax,
Yes.
and paralysis of intercostal muscles
Very good.
and hypotension.
Okay. Can you tell me, since this block was given at T3 and T4 level, how do you determine the right level?
I will determine according to type of surgery, which
Yes.
type of surgery I am giving. If it is upper abdomen, I will give T4 level, and if it is I am performing intestine, T6 level, and if it is TURP or hip surgery, then T10 level, and then goes down L1 level, L2 level, and ankle is S2 level. This is the level which I have to choose during which type of surgery. Then I have to give at that level, I will give epidural analgesia.
Okay, good.
Anesthesia.
Satisfactory answer. Okay, can you please tell me what are the factors that affect the efficacy of the epidural block that you are giving?
A factor, how much dose I have given, what is the age and weight and height of the patient, posture, level of the block, and duration. These are the factors that affect the efficacy of the epidural
And
anesthesia.
the dose and the type of medication as well. Okay, good. Can you please tell me what are the systemic effects that epidural block can have on the patient?
As a patient will go in vasodilation and hypotensive shock and bradycardia, and
Yes.
it cause decreased heart rate, decreased cardio output.
Cardiac output, yes, good.
Yes.
In it's leading to reduced vascular return.
Yes, vascular return will be reduced, and so cardiac output will be decreased.
Yes,
and
then reduction of
cardiac output, reduction of FRC, functional
Yes.
functional residual volume will be decreased.
Okay,
And
can you please tell me why you have decided to give epidural block to this patient and not the spinal anesthesia?
because it is a long surgery and it has good anesthesia as well as post-operative pain relief is good, and patient mobility will be increased, and there is less chances of DVT because patient can mobilize. So I choose this epidural block in this case.
Okay, can you please tell me why is it important to test for the temperature sensation rather
Because
than pain?
Because
in epidural block?
temperature sensation fibers are faster than the pain fibers. So I will use temperature sensation because it is fast to detect.
Okay, can you please tell me in case of epidural block, how would you differentiate it from a hypovolemic shock?
In epidural blockage, hypotension is there, and but there is warm peripheries, pink color distal peripheries, and warm. While in hypovolemic shock, although there is hypovolemia, hypotension, but peripheries are cold and pale.
And there'll be tachycardia.
Tachycardia, yes.
Yes. Okay. Can there be any contraindications when you cannot give epidural block to the patient? Can you mention few?
Yes, there are absolute and there are relative contraindication. Absolute, patient refusal, allergy to medication, and there is coagulation problems, and infection, sepsis, and relative are that there is a spinal problem, spinal operation, and these are the coagulation profile.
Okay.
Yes,
these sequelae of symptoms, if they progress, how would you realize, or when would you say patient is getting better or patient is getting worse?
If this is progressive, then patient will continue in the bradycardia, in hypotension and resistant hypotension, bradycardia not responding to IV fluids and drugs. And batteries and her peripheries are warm, although warm. And the better prognosis is that bradycardia improve and BP
Yes.
will go up.
How would you determine that patient is suffering from overdose or toxicity? Once you're giving epidural block, when would you determine that now it's patient is suffering from toxicity or the overdose?
Overdose signs like bradycardia and hypotension, and maybe patient. Yes, in these are the two factors that patient is overdose toxicity. And
what are the inotropes that can be used safely in this patient?
Inotropes that heart rate positive inotropes will be used like epinephrine, and I can also give dopamine, dopamine.
Can you tell me the types you can classify, and can you please tell me the types of inotropes? What are positive inotropes? What are negative inotropes?
Positive inotropes that increase the heart rate, and negative like epinephrine, and negative inotropes that decrease the heart rate, decrease muscle contracture like propanol. And there are also mixed inotropes, alpha inotropes, beta inotropes. These are.
Yes. Okay. Good. Thank you.
Thank you, madam.
Very good. Right. So if you have read and understood, considering clinical examination station, can you begin?
Okay. Good. I'll wash my hand. I'll enter. I'm Dr. Kolade. I would like to confirm your name and age, please.
I'm Lisa, 54 years old.
Okay. Good. Nice to meet you, Nessa. Can I hope I can call you Nessa?
Yes.
Okay. I want to examine you today to involve me looking at your tummy, touching, and then asking you to move and do some other things. Hope it's okay by you.
Yes.
Okay, all right. And I will ask the patient to first sit in the cardiac position, then I will do adequate exposure. So I will expose her from the nipple line, making sure that she's putting on her bra.
Would you be needing a chaperone?
Yes, and then call it chaperone.
Yes.
Making sure that her bra is intact,
yes.
and then her pint are also intact, then to the neck. So I'll first do a quick general examination. So I will check her eyes to look for jaundice and pallor.
Yes.
Check her mouth for any angular stomatitis or the level of dehydration or hydration status also. Then I will look at her hands to check for feeder finger clubbing, and then dubitary contracture or palmar erythema. Then I will let her lie flat. Then I will look at her tummy at the foot of the bed, and also come to her bedside and see to check whether the tummy is rising or not. Then I will look out for any swelling, if there is any change in color, especially around the periumbilical region where she has a swelling. I will know the size of the swelling, if there's erythema, if there's any scar over the swelling, and then if there's any discharge or anything. Then I will tell her to cough a bit if she can cough. Then if not, then if she can't, when she's coughing, I'll try to see if the swelling becomes bigger or not. Then I will tell her, Lisa, I want to touch your tummy. Apart from your umbilicals, do you have pain in any other part of your tummy?
No.
Okay, all right. Please, if you have pain as I'm going, please do let me know. And if
Okay.
you have pain, do you mind if I give you analgesics?
Okay.
Okay, so I will sit down and then palpate. I'll first do light palpation through all the regions. I'll start from the right, go down, then end at the peri-umbilical region. Then note the tenderness over the mass. I will measure the size of the mass to know the size. Then if it's tender, if it's also warm, if there's differential warmth over it, and then if it's if it is pulsatile, then after that I will do deep palpation to check the size of liver, and then also check this if there is a light, and also the spleen is also enlarged below the costal margin. Then I will percuss around the umbilical, the right side to check the liver span. Then I will also ballot the Achilles. Then for the swelling, I will also put my stethoscope to check if there is any bowel loop. If there's bowel sounds there, then I will check a bowel sound on the left iliac fossa to check if there is if it is reduced or if it is normal because of possible intestinal obstruction. It's possible that it may be reduced depending on what is inside what I've fed inside the peri-umbilical region. Also in the peri-umbilical region, I will try and see if I can reduce the swelling if it is possible, but if it is not, I won't force her, and if she can't reduce it. But if there are features of inflammation, I won't bother to reduce it so as not to reduce the gangrenous or inflamed content back into the abdomen. Then I will check I'll try and palpate the abdominal aorta to see if there is swelling if it's possible. But if the pain is not making out, so I won't do that. Then auscultate over to listen to any aortic brew, then both renal artery brew, and then also auscultate over the liver to check if there is any brew over the liver. Then I also auscultate down from the umbilicals down towards the bladder to see if there is any swelling or bladder distension. So I will thank her, then I'll offer to assist her to dress up. Then I'll wash my hands.
Okay. You still have 1 minute. Right. What else you would have ruled out?
Oh, then what else I will have ruled out? Then I forgot. I will also check the lymph nodes,
Yes.
especially in the neck,
Yes.
the vitreous node, to see if there is any intra-abdominal mass that could metastasize to that place and cause that
Yes.
could also leave a metastasis or a swelling around the peri-umbilical region also.
Right. Did you examine the hand of the patient?
Yes, I mentioned it. I examined
Yeah.
the hand for primary erythema, dubitrine contracture, finger clumping, and leukoleukemia.
Yes. Right, just a few seconds left. So maybe you can, yes, can you please present your examination now?
Okay, I've examined a 54-year-old woman
Yes,
that has a peri-umbilical swelling.
yes,
Is tender, no differential warmth.
yes,
She has tenderness around the peri-umbilical region, but no
yes.
guarding. The liver, spleen are
How
not
big is
palpable.
how big is the,
Yes, the swelling is about 4 by 4 centimeter.
okay,
Then not fluctuant, and then not fluctuant,
okay,
and not pulsatile also. And the bowel, there is no bowel sound over the head over the swelling.
okay,
There is no the liver, spleen are not palpably enlarged, and the kidneys are not ballotable.
okay. So what are your provisional diagnosis?
My professional diagnosis will include a peri-umbilical hernia,
Yes,
which is non-reducible.
okay. So how would you confirm your diagnosis?
To confirm my diagnosis, I want to do an abdominopelvic ultrasound to look at the swelling, to better
Okay.
assess the swelling, the origin, the content, or if
Yeah.
possible, also I can even request for a CT scan. Then I will ask the patient. I can also do a plain abdominal X-ray to rule out any features of intestinal obstruction.
Okay. So what are the treatment options that you can offer to this patient?
Yes, the treatment option, if it is PERI-UMBILICAL hernia, it can be patient to benefit from an aneurysm, which can be done either open or laparoscopy.
Okay. Would you not ask the patient to reduce the weight and do the lifestyle modifications?
Yes, yes, ma'am. Before the surgery, I would like her to reduce her weight, at least to become overweight, or if she can get to normal weight, to be better.
Yeah.
So that's to reduce the risk of recurrence and also make the surgery much easy and reduce the chances of infection.
Considering the current condition of the patient, would you recommend using mesh or laparoscopic mesh here, or
Yes, I would prefer a laparoscopic mesh, ma'am.
why?
And because of her size, because of she's obese, the possibility of being able to do a primary tissue repair and failing is higher. So putting a mesh to augment the defect is better.
Wouldn't that lead to more foci for infection since the patient is obese?
No, she will have been. I would have asked her to undergo lifestyle modification to get to normal weight or at worst overweight. But the chances is there, but it doesn't mean that she will get the mesh is going to get infected, because it's a clean procedure.
Yeah. Hey, thank you so much.
Thank you, ma'am.
Started, and here is your question. Right. So if you have read and understood, considering a critical care scenario, kindly tell me how would you manage this patient next?
I would manage this patient according to the CREST protocol,
Yes.
and it will involve the assessment of the patient according to the A, B, C, D, E role. I will first assess the airway of the patient and will attach high flow oxygen to the patient if the patient has a patent airway. And then I will assess the respiratory system of the patient by assessing the respiratory rate and cyanosis of the patient, and also the chest movement, and then the position of the trachea. And I will also auscultate the chest for the air entry bilateral. Then, as the patient is a hypotensive, I am suspecting the hypovolemic shock in the patient, and I will pass 2 wide bore IV needles in the antecubital fossa, and the antecubital fossa, and I will resuscitate the patient with the crystallized solution. Along with that, I will attach the cardiac monitor and will check the pulse, blood pressure, peripheral warmthness, and also the will attach the pulse oximeter to the patient.
Okay.
I will take the blood samples
Yes.
for I will
Mhm.
take the blood samples for routine blood labs, and also for the cross match at least four blood units, and
All right.
I will also
Yeah.
pass
And-
the Foley's catheter.
Okay, very good. Thank you. Can you please tell me what measures would you do to stop the bleeding or to manage the hemodynamics of the patient?
To manage the hemodynamically patient, I will first resuscitate the patient with crystallized solution, also
Okay.
known as the volume expanders.
Yes.
Then I will send the blood samples for a cross match, and to stop the bleeding, I would administer tranexamic acid,
Can
as
you
well as
mention 3 different components of the blood that can be given to the patient?
these are platelets,
And
leukodepleted RBCs, and FFPs, and
yes,
cryoprecipitates.
what is cryoprecipitate?
These cryoprecipitates are these are saturated.
How much of cryoprecipitate can be given, and what is the shelf life of cryoprecipitate?
We can give. Actually, I don't know.
Okay, we'll come back to this one later. Can you please tell me? Right, you told me all this. So can you please tell me? You said you'll arrange approximately 4 units of blood for this patient. How you came across this this figure of 4 units of blood for this particular patient?
This patient has sorry, ma'am, can you please repeat the
Yes.
question?
Can you please tell me how you came across the figure of 4? What factors do you have to consider in order to make sure how many units of blood you have to prepare or arrange for the patient?
So how many units? This depends upon the expected loss of the blood volume.
Very good. And would you maybe
And
consider
also
the weight of the patient, comorbidities?
yes, so comorbidities and weight of the patient, and yes, ma'am.
Okay. Can you please tell me what you understand by the term massive blood transfusion?
Massive blood transfusion means transfusion of the blood at least one whole blood volume for the 24 hours, or more than blood
More than
50%,
50,
or
yes.
the more than 50% replacement of more than 50% of the blood volume in 4 hours.
For a 70 kg male.
So it is 70
adult.
kg per, yes, 70 ml per kg.
Right. What would be the definition of autologous blood transfusion? Or what do you understand by the term autologous blood transfusion?
The term, what is the term, ma'am?
Autologous?
Autologous. Yes, ma'am. It is a medical procedure in which the patient, blood from the patient is the lost blood from the patient is recovered, and then it is processed through some machines, and then reinfused in the patient to avoid the blood loss.
The blood transfusion is responsible for many complications. Can you name few?
Blood loss. Blood loss or blood transfusion?
No, blood transfusion, I said.
Yes, blood transfusion can lead to some immunological complication and non-immunological complications. Among immunological complications, this is acute autoimmune hemolytic anemia, pyrexia, and then febrile, then graft versus host disease.
I think you're telling me something else.
Ma'am, I am telling the complications of blood transfusion.
Yes.
Yes, ma'am. These are categorized into immunological and non-immunological. Among immunological, these are acute,
You told me these.
acute
Yes. You
autoimmune
tell me the,
hemolytic
yeah,
anemia,
yeah.
the fever, graft versus host disease, and anaphylaxis. And in non-immunological, these are acute heart failure, then hypocalcemia, hyperkalemia, and fluid overload, and even hypothermia.
Yes, okay. Can you tell me how this hypocalcemia due to chelation of calcium, how this leads to adult respiratory distress syndrome, or how this blood transfusion can lead to adult respiratory distress syndrome?
This leads to transfusion-related acute lung injury.
Yes.
And whenever there is a transfusion-related acute lung injury, and there is damage to the alveoli of the lungs, and this leads to the acute respiratory distress syndrome.
Okay, can you please tell me, right, if you have to compare fresh blood for transfusion as compared to the stored blood, so what are the clotting factors which are deficient in the stored blood?
Factor 5 and factor 8.
Okay, it's all the essential ones are absent. Okay, can you please tell me what do you understand by the term, right, Bell is gone, okay. Right. If we could just come and discuss.
Can I tell
Sure.
something, ma'am?
Yes, please. I was going to ask him about the, yes, please, first, Dr. H.K.
Yeah, as it is a case of rupture abdominal aortic aneurysm, right?
Yes, I was going to
Yes.
ask him those questions. Yes.
Yes. So, Doctor, would you go for resuscitation first and then management of the patient, or you would go for resuscitation and management simultaneously?
I will go for resuscitation as well as the management simultaneously. Along with the resuscitation, I will also consult the miscellaneous, as well as I will arrange for the chest X-ray and abdominal ultrasound. If the patient is stable, abdominal ultrasound can be done, and that will be.
This
And then
patient
I
is
will
not
be.
stable.
Sorry, if the patient is unstable. Sorry, if
Yes.
the patient is unstable, I would manage.
Yeah, this
I
patient
would
should be taken to the OR immediately,
Yes.
and then
then immediately to the theater. Immediately after consulting with the consultant, I will and ITU registrar and with the anesthesiologist, I will be shifting to the patient to the emergency operation theater. And if the patient with my resuscitation, the patient becomes stable, then I can go for CT scan and then shifting the patient to the operation theater while consulting with the seniors.
no, this particular patient, they don't do CT scan or ma'am.
Yeah, I will not go for
You
CT
will
scan.
not, that will be just, but okay, just here, consider. First, you have to know what type of aneurysm is abdominal aortic aneurysm. And then you have to consider the size of the aneurysm. If it has already ruptured, then it is lethal. And in men, especially when it ruptures, then it's lethal. It's like really rare when they can be saved, especially when they are so old. So as long as it's not ruptured and you make sure it's not ruptured with ultrasound, you can confirm it. Then you shift the patient straight to OT and you operate it. But if you will resuscitate and you'll be wasting your time, you'll compromise with the patient. This is what my knowledge says. Dr. HK, you can add.
Yeah,
What
to
you
my
say.
knowledge, there is one classification NCPOD,
Yes.
if you can remember.
Ten
This
folds.
patient NCPOD, this the National Confidential Outcome
Yeah.
of Patient Death. This patient should be taken to OR immediately, and resuscitation and management should be done simultaneously.
Yes, I
That's
did
all.
ask
Yeah.
him that how would he make sure, what would he do to stop bleeding? Because patient's aneurysm
Yeah, it
has
should be
already
open.
ruptured.
The
Should have been
laboratory,
operated.
yeah.
Sure. Okay.
Okay.
Thank you
Madam,
so much.
I think if this patient is in hypovolemic shock, his BP is not stable, so he will go directly to the operation theater. If there is retroperitoneal hematoma, then patient will be stable. Then and by permissive hypertension, permissive blood pressure, permissive hypotension, we can stabilize the patient by controlled fluids and do the CT scan. Then patient can go to endoscopic treatment or OT if there is retroperitoneal hematoma. But this patient
Yeah.
will go to operation theater because he is not stable. Permissive hypotension, if stabilize the patient, then patient will go to CT scan and endoscopic stenting.
Right. Good. Thank you, Dr. Zulkarnain. Can you tell me what is the what is the schedule or the protocol to follow patients with abdominal aortic aneurysm according to NHS? How frequently would you be following them, and if there
Well-
is any protocol, first of all?
Yes, ma'am. We will go for ultrasound of the patient, and we'll check the size of the aneurysm. And
How frequently?
sorry, ma'am. Then we will go for ultrasound yearly, and we'll check if there is change in size, and if the patient's size of the aneurysm increases, then we will
Increases to what size, please?
more than 2 centimeter yearly.
1 centimeter per year.
1 centimeter.
Sorry, 1 centimeter per year. Then
Yes.
we can go. Then we will consider the treatment.